So, in our talk about the radius and ulna shaft fractures, we will start with an introduction. So, the radius and ulna shaft fractures occur commonly, and the radius and ulna are linked together. They are linked by the proximal and distal radio-ulnar joints, and they are also linked together by the interosseous membrane. And because they are linked together, they get fractured together in most cases. But a fracture to a single bone can occur in some cases. Now, most of the single bone fractures, so it is either a fracture to the radius or a fracture to the ulna, are associated with another injury at another level. But some of them occur in isolation. So the single bone forearm fractures occur with associated injury in most cases, and they might occur in isolation in some cases. Now, examples of the single bone forearm fractures associated with a second injury include the Monteggia fracture dislocation, the Galeazzi fracture dislocation, and the Essex Lopresti injury. Now, the Monteggia fracture dislocation is an ulnar shaft fracture with a radial head dislocation, while the Galeazzi fracture dislocation is a fracture to the radial shaft with a distal radio-ulnar joint injury, and the Essex Lopresti injury is a radial head fracture with a distal radio-ulnar joint injury. And in this video, we will explain the both forearm bone fractures, and we also will explain the single isolated forearm bone fractures. Now, the Monteggia and the Galeazzi fractures will be explained in the next videos, and the Essex Lopresti injury was explained in the previous video of this class. Now let's talk about the mechanism of injury. So the mechanism of injury in forearm bone fractures mostly is a fall on the hand that produces a spiral or a transverse fracture of both bones usually. And sometimes an injury to the forearm bones can occur from a direct blow to the forearm causes a transverse fracture of just one bone, and that's mostly the ulna. In high energy injuries, the fracture might be comminuted or segmental, and additional displacement is achieved by the muscle pulling produced by the muscles attached to the radius and ulna, like the biceps, the triceps, the brachialis, the supinator, the pronator teres, and the pronator quadratus. Now, to really understand the radius and ulna shaft fractures, first we have to understand some points about the anatomy of these bones. So, the forearm consists of two bones, the radius and ulna, and they articulate with each other through two joints. One joint is proximal, and it is the proximal radio-ulnar joint, and the other one is distal through the distal radio-ulnar joint. So as you can see in this picture here, we have the radius and ulna, and they articulate with each other through the proximal radio-ulnar joint here and the distal radio-ulnar joint. And the whole forearm is considered a joint capable of rotation. So the forearm is capable of pronation and supination. And because of the fact that the whole forearm is a joint, this means that fractures anywhere on the radius and ulna are considered an intra-articular fractures. And with intra-articular fractures comes a higher risk of stiffness. And also, the radius and ulna articulate through hinge joints with the humerus proximally and the wrist distally. And those are the articulations with the humerus here and the wrist here. And the hinge joints allow for flexion extension type of movement. And in addition to that, the wrist joint allows for radial and ulnar deviation type of movement. So the elbow joint allows for flexion extension only, and the wrist joint allows for flexion, extension, radial deviation, and ulnar deviation. Now, it is important to know that loss of the normal shape of the radius or ulna during fractures will result in restriction of the normal pronation, supination movements. And that means that these bones has to be reconstructed perfectly, except in pediatric population, because pediatric bones tend to remodel well, but still there is a specific acceptable displacement criteria that has to be followed. Now, it is also important to know that the muscles of the forearm are contained within compartments separated by fascial envelopes in a narrow space, which is the forearm. And this means that there is risk for compartment syndrome when the pressure increases in these compartments, especially in high energy injuries. Now, in the forearm, we also have ligaments that connect the radius and ulna together, and those include the annular ligament and the interosseous membrane and the triangular fibrocartilage complex. The annular ligament is in the proximal radio-ulnar joint, and it starts from the ulna and it goes around the radius and goes back to the ulna. The interosseous membrane, on the other hand, consists of 5 different ligaments. Those include the proximal oblique cord, the dorsal oblique accessory cord, and the central band and the accessory band, and the distal oblique bundle. And we also have the triangular fibrocartilage complex in the distal radio-ulnar joint. In the forearm, we also have nerves and vessels that pass through the forearm, and those are capable of getting injured during forearm bone fractures. And those include the anterior and posterior interosseous nerves, the ulnar nerve, the radial nerve, and the brachial artery, which divides into the ulnar and radial arteries. So here we have the anterior interosseous nerve, and here is the ulnar nerve, here is the radial nerve, and here we have the brachial artery, which divides into the radial artery here and the ulnar artery here. And all of these are liable to injury, as we mentioned. Moving on to talk about the clinical features of a patient presenting with a radial and ulnar shaft fractures. So they present with a pain and deformity of the forearm, and you take a full history from them and you make sure to ask if there is pain in the wrist or elbow to make sure that there is no associated injury to these joints. Now, regarding the physical examination, so we have the same maneuver of look, feel, move. On looking, you look for swelling. Deformity might be seen if there is severe displacement, and inspect the lacerations for any evidence of open fracture. On feeling, you feel for tenderness in the forearm, and you also feel for tenderness in the elbow and wrist. And a neurovascular examination is done to look for nerve and vessel injuries. And on moving, you ask the patient to move their limb, but they refuse movement because of the pain. And examination is repeated multiple times to exclude compartment syndrome. Now let's talk about the imaging. So imaging in these injuries is through plain radiographs, and those include the anterior-posterior and the lateral forearm radiographs, and those are enough for diagnosis. And the radiograph should include the elbow and the wrist to detect any injuries in the proximal or distal radio-ulnar joints. And on those pictures, we have an example of an anterior-posterior and the lateral forearm x-rays, and it shows the forearm bones, the wrist, but it does not show the elbow joint. So it's already one mistake on this x-rays. But anyways, it shows both forearm bones fractures, so a fracture to the ulna and a fracture to the radius. And you can see that there is displacement of the radius bone and there is minimal displacement of the ulna. Now let's talk about the treatment of the radial and ulnar shaft fractures. So we either have an operative treatment or an operative treatment. So non-operative treatment is done by closed reduction and immobilization of the fracture. And non-operative treatment is commonly done in pediatrics, and it gives an excellent result because the periosteum in the pediatric population is strong and guides the reduction process. And the non-operative treatment is rarely done in adult patients because it is difficult and result in unstable reduction, so operative treatment is superior in adult patients. Now, after close reduction of the fracture is held in above elbow back slab to prevent rotation. So the back slab should extend to above elbow to prevent rotation of the forearm during the immobilization process, and the fracture is immobilized with the elbow at 90 degrees and it would be supported by a sling. Now, in cases where the radius is fractured proximal to the pronator teres muscle insertion, the forearm is immobilized while being supinated. While in cases where the radius is fractured distal to the pronator teres muscle insertion, the forearm is immobilized while being in the neutral position. Also, in the non-operative treatment, the neurovascular examination and the plain radiographs are repeated shortly after reduction to make sure that the reduction is good and there is no nerve or vascular injury occurred during the reduction. And the plain radiographs are repeated again after a week to make sure no further displacement has occurred and the forearm is immobilized for 6 to 8 weeks. And exercises are started as soon as the pain allows, including hand and shoulder exercises to prevent stiffness. Now let's talk about the operative treatment of the forearm bone fractures. So the indications include failure of close reduction, unstable reduction, and open fractures. And operative treatment options include the percutaneous spinning, the open reduction internal fixation with intramedullary nailing, open reduction internal fixation with the plates and screws, and this is the most common method used, and open reduction internal fixation with K-wire fixation. Now, open reduction internal fixation is preferred in adults because closed reduction is difficult and redisplacement is common except if the fragments are in close contact to each other. In that case, the closed reduction and immobilization is justified. Now, during the operation, the deep fascia is left open to prevent compartment syndrome and only the skin is sutured. And after the operation, the arm is kept elevated until the swelling subsides and exercises are started as soon as possible. Finally, let's talk about the complications of the radius and ulna shaft fractures. So we have an early complications and a late complications. Complications include nerve injuries, and nerves that could be injured in those fractures include the anterior and the posterior interosseous nerves, the ulnar nerve, and the radial nerve. Another early complication is the vascular injury, and the radial or the ulnar arteries can be injured, but it is of no problem since the collateral circulation will satisfy the requirement. The third complication is the compartment syndrome. This is very important to look for because it might end up with amputation. So damage to the forearm muscles lead to bleeding and swelling, and this may lead to higher pressures inside the muscle compartments, impaired circulation, and would end up in a compartment syndrome. Late complications include malunion. This occurs with the closed reduction. There might be angulation, rotation, or shortening that would end up in malunion. We also have delayed and non-union, and those are rare. And we also have complications of plate removal, and those are common, and they include nerve and vessel damage, infection, and refracturing. Late complications also include synostosis, which is cross-union of the radius and ulna, leading to fixation of these bones, and this means that rotation of those bones like pronation and supination would be impossible. And the final complication is stiffness, and stiffness occurs because these fractures are intra-articular fractures. And with that, we reach the end of this video. Thank you guys for watching. Please give us a like and comment your ideas and questions. And this video is a part of a bigger class. It's called the Elbow and Forearm Trauma Masterclass. You can check it out. Link will be in the description of this video.